Thank you, Chris. It is a great pleasure to be here today to talk to you about a very important health issue. And I look around and I see many others who were born in the first half of the last century, as I was. So this is a subject that is not only something I have been investigating and treating and managing in many patients for decades and decades and decades, but it's an issue that I also have to consider as one of the problems that I may encounter going forward in the rest of the many wonderful years in my life and in our lives. So thank you for having me here. We're going to talk about a very important condition called carotid stenosis. It is common. It is one of the important preventable causes of stroke. So that's our subject, carotid blockage in the neck, an important cause of stroke, and I'm going to see if I can make this go forward. This one? There we go. You recognize the gentleman on the far right, Senior Senator Heflin. I want to as we all know, we look back at these photographs of many years ago to give you a sense of how long I have been taking care of patients both with coronary heart blockages, but also blockages in the neck. And after Senator Heflin was saved with the first coronary stent when he was aired back down to UAB when I was professor of cardiology there, he went back to the Congress and made the statement in the Senate, and the stent was the first coronary stent approved. And in fact, I wrote a book about that, and you can buy this book on Amazon.com, and you may be interested in the history of the heart stent and how it was developed and the importance of Birmingham and UAB and Alabama in the development of that device, which has in fact gone on to save the lives of millions and millions of patients over the last 25 years. My next project after that coronary heart stent was to think about the blockage that occurred in the neck, and that was responsible for many, many, many of the strokes that we see in our cardiovascular practice. And so at UAB with Dr. Yuri Vitek, my colleague Dr. Ayer, and myself, you can see I still had a lot of more dark hair in those days, so that's how long I've been speaking and investigating and studying this problem. We developed, again, the first stent ever to be used to treat blockages in the neck. So this is an issue that I feel very passionate about, a very important issue. Why? Well, stroke is the #1 cause of death and disability in the United States, beyond cancer, beyond heart attack. It not only takes our lives, but it can debilitate us, and I think most of us of this age where we're at some risk would always feel that there are some things worse than passing. To be totally debilitated, bedridden, unable to speak, is somehow worse than the alternative. So it's a very, very important problem. It occurs about 500 to about 500,000 patients every year in this country. This is an important slide because if you look, whoops, this one, there it is. If you look right here in Alabama, the dark is where there are more strokes occurring. There's something about what we do here in the South that makes us prone to having this disease that affects our heart, that affects the blood vessels, as I'll explain, going to the neck and causes these strokes. And that there are many causes of strokes, and I'm going to focus on this one today because this is one cause of stroke which is now very preventable. And there's new information and new data and new techniques and new medicines that you all should know about. And that's what we're talking about for the next 20 or 30 minutes here this morning. So what is a stroke? Let me ask a question. Anyone suffered a stroke in this room? We have some stroke victims, fortunately not too many. Has anyone had a diagnosis of a blockage in the arteries in the neck going to the brain? We have some takers. Very good. Has anyone had surgery to remove the blockage, called endarterectomy surgery? And has anyone had a stent? Well, that's another alternative. So now let's talk about this problem. So a stroke is when there's some damage to the brain. And there's the brain. Oops, I'm going too fast here. No, going the wrong way. I apologize. I'll get to manage this. And what happens when we have a stroke is that part of the brain is damaged when a little bit of particle or blood clot breaks off from the blockage in the neck, goes up to the brain, and damages that part of the brain. This is called an ischemic or embolic stroke. There are other causes of strokes. Hemorrhage. Hemorrhage can cause stroke. But this ischemic embolic stroke is one of the most important causes. Now there is a heart condition called atrial fibrillation that some of you may have that can cause this. And that can be treated as well, treated very well these days. But these blockages in the neck are another very important cause of this stroke condition. This is an example of what happens when you have a hemorrhage in the brain, which is far less common than a piece of blood clot floating up to the brain. And we need to ask the question, why do these blockages occur? And these blockages occur because of the same risk factors that produce atherosclerosis or blockages throughout the arteries in our body. As we get older, we get more prone to these blockages. Smoking is the number one cause that is most preventable. High blood pressure is very important. Abnormal cholesterol levels are very important. Insulin resistance or diabetes is very important. And of course, obesity and sedentary lifestyle. So we all know about these factors. Most of you have been paying attention, which is why you're here today. So these factors cause these blockages to occur in the artery in the neck at about this point, right behind the angle of the jaw here. It's called the carotid bifurcation. And as this blockage builds up, it's prone to cause blood clots, which can then float up to the brain and then cause a stroke. And this is a diagram of this part of the artery in the neck. And this shows the blockage, and it's very interesting that the blockage just occurs in a very special spot. Why is that? We don't know for sure, but we think it's because of the blood flow hits this branch point, this bifurcation it's called. This blood vessel goes to the face, this one goes to the brain. And so this blockage is usually short, very discreet, and very amenable to treatment. Let's talk about first how we find out if we have this blockage. If you have, as a patient or as an individual, have any of these risk factors, then your physician will order a simple ultrasound test. And I'm sure many of you have had this. And this is very, very accurate in diagnosing whether you have some plaque in that spot in the artery. And it's actually very common. And about 50% of people who have had any heart problems will also have blockage up here. Maybe one side, maybe both sides. That's the way it occurs. And that's called carotid duplex ultrasound. Very safe, a very simple test, but a very important test in determining if someone has this blockage. And this is what the scan looks like, which is too complicated, except to know that we get these very special numbers which tell us how bad the blockage is. But more importantly, this is a normal artery, and here you see where that arrow is. Can you all get the picture here of how that is narrowed right down to a severe blockage? It's another example. And what is the problem? If the blockage is severe, then this material can break off and float up to the brain and cause a stroke. So that's the embolus, that's the cause of a stroke. It's not the blockage per se, it's the fact that the blockage causes these blood clots can then break off and float up. So many of us will have blockages, but only some of us need to worry about specific treatment. The general treatment is not to smoke. Take your cholesterol meds, get some exercise, eat well, control your diabetes, etc. But who do we need to treat? There are patients who have a blockage that is very severe, like this one, narrowed right down, right here. Or there are patients that have symptoms, and they're very specific symptoms, and they involve specific trouble with the vision in one eye, often involves speech, or it often can cause numbness, weakness, palsy of one side of the body or the other. So these are examples of normal arteries and blocked arteries that we treat all the time. So if we feel that if we find out that we have a blockage, I want to spend the next few minutes talking about the options for treatment, because this has really changed over the last even 5 years. So what are the therapeutic options? What would I talk to you about, or your doctor talk to you about, if you were diagnosed with this blockage? Well, at the top is medications. And there are very specific medications these days that can prevent the blockage from causing a stroke. And we've studied them very carefully, and we know they work. So that is one option. So as well as stopping smoking, getting exercise, watching your diet, medications to control your blood pressure, medications to control your cholesterol, and medications that specifically work on the plaque to make the plaque more stable and prevent blood clots from happening. They're all available in many different forms. Now, it used to be that when we discovered a blockage, that we would immediately panic, and you said this has undoubtedly happened to some in this room. You would be told you have a bad blockage, it's going to cause a stroke, it has to be fixed. Well, to fix the blockage over the last 40 years, 50 years, has been an operation on the neck that I'm showing as an example over here, where the surgeon cuts a fairly short incision and pulls out the plaque. That's called carotid endarterectomy. It's a great operation. It is very safe and has been proven to be very effective. But it does involve general anesthesia. It does involve an operation with the risks that go with surgery. The alternative that we developed at UAV, now 20 years ago, was just to come in from the artery under the skin at the top of the leg, the femoral artery, and go up to the arteries going to the neck, which is really a straight highway, and put this little mesh in called a stent. Now this is done without general anesthesia. It's done with the patient wide awake talking to me. Just local anesthesia. You don't feel anything. And it has been proven to be equally as effective, but probably safer than the surgical option. And in fact, one of the major studies that we performed in the early part of 2000 to 2010 was a trial where we compared the stent and the surgery, and this is a National Institutes of Health trial. I was one of the lead investigators, and we showed that this landmark, reading the red, NIH clinical trial comparing these two stroke prevention procedures shows that surgery and stenting equally safe and effective. So now we have two options. And why do we need two options? Well, because some patients actually are better candidates for surgery because of the way their blockage sits. And some patients are better candidates for stenting. So it's not an either-or. They're two complementary options, which really broadens the safety and the therapeutic options for patients that have this blockage. But this is one of my patients from New York. He came in at 7 o'clock. I put the stent in. It takes about, once I get the patient all set up, about 10 minutes, and he went home at 3 p.m. So it's a percutaneous, less invasive, and procedure that can help you avoid surgery. But a very important point is that not all patients are suitable for the stent procedure. And these are some diagrams of lists of all of the reasons. And many cardiologists, many vascular surgeons still do not understand this incredible technical detail that goes in selecting the right patient for the right procedure. If you have a lot of plaque in the aorta, or if you have an artery that's very curly-Q, see how it bends here? If you have this type of aortic arch, that's the main artery, you're not suitable for a stent. You're better off having the surgery. So these are very, very important reasons why we need surgery in some patients, and we need stenting in other patients. And it's important that you see a physician who understands the differences between these issues to make good decisions for you. Now, that's the background. And now what's happened just in the last 2 or 3 years with carotid blockage? Well, the National Institutes for Health has decided that we still don't know enough. We don't have enough data to make good decisions about the hundreds of thousands of patients in North America, throughout the world, who have these blockages. And why is that? It's because in the last 5 years, we've learned so much about the pills. Remember I said there were lots of good medicines for preventing these blockages from causing a stroke. They can even make the blockages shrink a bit. They certainly can make the clot go away. Blood pressure medicines, antiplatelet agents, we call them aspirin, Plavix, others. Some of you are probably on these meds. Medication for cholesterol, of which there are many varieties now, and they get better every year. That if you just take the medicines, you never need a stent. and you never need surgery. Now, wouldn't that be a wonderful thing? Because although the surgery and the stent are very, very safe when performed by experienced operators, I've done about 3,500 of these procedures. They're very safe, but they're not perfect. And a stroke, which is less than 1%, can occur during the procedure. So if you just take a pill, don't have to go into the hospital for a procedure, wouldn't that be great? Or as Donald Trump would say, it'd be huge. So the National Institutes of Health has started another program called the CREST-2 trial. This is very important because in Birmingham, since I'm at Brookwood, we're leading this trial and teaching actually physicians around the United States how to do this, how to do that, how to make best decisions for their patients. And so the CREST-2 trial is a prospective randomized trial where everyone gets these wonderful new pills. And there's a large body of thought from neurologists and some surgeons, some cardiologists that say that's all you need. We can do away with surgery, we can do away with stenting. But we don't know. We only think we can. Now in medicine, when we only think we know what we're doing, we're better off doing rigorous science. And these scientific studies then guide us on really what is best practice. And so there are many, many physicians with great confidence make wonderful guesses about what's best for their patients. Then there are other physicians with great confidence use scientific data to make the best decisions for their patients. Well, this CREST-2 trial is underway, and what does that mean? It means that we divvy up the patients. We say, you're good for surgery and medicine, or you're good for surgery down here, you're good for stenting. So 3 excellent treatments. You're either going to get the pills and the stenting, or just the pills, or the surgery and the stenting, and the surgery and the pills, or just the surgery. So it's a randomized trial. And at the end of the day, what it will do, it will tell us, so we either get pills and surgery, or pills and stenting. If you think about it, 2 excellent treatments combined. Or you just get the pills. And since we think the pills may be as good as the surgery or the stenting, they're 3 wonderful choices. So throughout the country now, at Mayo Clinic, Duke Medical Center, Harvard Hospitals, Stanford, Brookwood Medical Center, if the patients are suitable and want to participate, the patients are going into these options. 3 incredibly good, safe treatments, all of which are great, but we don't know if over the 4 years, 5 years, one will turn out to be better than the other. So that's the CREST-2 trial. And this is new, and this is information that most physicians are really still not familiar with, although we did get an article in Birmingham News last week. So we have a blockage. We know that blockage may cause a stroke. We're told the blockage is severe. And now we have all these treatment options. And so if I was sitting there and I was you, and a conversation I had with 5 patients yesterday in clinic, so doc, now I'm totally confused. So what's the best for me? What would you recommend? So thank you very much. That's where we stand, and I'm happy to answer all your questions.